Okay, so hello everybody. This is Ed Levin. I'm director of the Center on Addiction and Behavior Change, part of DIBS, Duke Institute for Brain Sciences. And welcome to our seminar series. This is the penultimate, the next to the last seminar for this semester. And I just wanted to, before introducing today's speaker, look ahead a little bit. We have one more speaker. This is Roy Stein and Robin Jordan are going to give a joint presentation. They're both at the University of North Carolina, just down the road at Chapel Hill. Roy, for a long time, was a psychiatrist here in our own psychiatry department at the Durham VA. And they're going to be speaking about expanding access to opioid use disorder treatment, the hub and spoke model. And then that'll do it for the fall semester. And then we're going to pick right up in the spring. I've finished the putting together the spring seminar schedule, and I've emailed that out to people on the listserv. If anyone else wants it, just drop me an email, edlevin@duke.edu. But we're going to be starting back up with Becky Klein from Duke and the Durham VA on January 20th, APOE for APOE, TBI, and voluntary alcohol consumption in the mouse model. And then we're going to have a series of speakers, more or less 2 a month, through April. And if anyone else has some burning desire to present, I suppose we can put another one in the spring semester, or I'm actually starting the fall semester schedule. So if you want to present, or if you have a suggestion for a speaker from the outside, and given that for the foreseeable future, we're going to be speaking with the virtual format, you know, the world is our oyster, I guess. That if you have someone you'd like to invite, that'd be great. So now it's my privilege to introduce Dr. Sandra Comer, who is a professor of neurobiology and psychiatry at the Columbia University Irving Medical Center. She earned her bachelor's degree at Vanderbilt University and PhD at University of Michigan, and did postdoctoral research at the University of Minnesota. She's a world leader in research on the effects of drugs using both preclinical and clinical models. And actually that's the basis for her talk today, this translation from preclinical to clinical work. As she is a world leader in the in this area, especially in terms of developing new medications and treating opioid use disorder. Was the president of the CPDD, College on Problems of Drug Dependence, the longest, the oldest such group in existence. So. Anyway, today she is going to be speaking to us about her work on medications development for opioid use disorder. How well do the results from preclinical and clinical studies align? Thank you, Sandra.
So thank you, Ed, for the introduction and for the invitation to talk to you guys. I hope it generates a lot of discussion at the end. Disclosures. We've received research funding from multiple companies and also have done consultation work. The way we're all feeling right now. Oh, shoot, it doesn't work. Well, anyways, so, you know, it's an anxious time for a lot of us, and a lot of uncertainty around what's going to happen in the US and around the world. So that's kind of the theme of my talk, actually, is uncertainty. So what I'm going to be talking to you guys today about is how well the data from, you know, preclinical or animal studies translate to the clinic, and backwards actually as well. And then also, you know, why do we even care about this question? So I'm going to tackle the second question first. As you guys probably have seen some data that are similar to this. The number of overdose deaths has increased pretty much exponentially over the last many years. And now a lot of these deaths are due to synthetic opioids, particularly fentanyl. So the other part of this equation is that the percentage of people who are actually receiving treatment is pretty low. So this is the percent, needing treatment as a function of those who actually get it. So there are lots of states in the US where the treatment availability is really low. Today I'm going to talk to you about medications development for opioid use disorder. And just to kind of provide a framework for you, I'll talk about target indications first, in terms of, what kinds of medications are being developed for what aspects of opioid use disorder. I'll describe pretty briefly some of the models that are used for each of these indications. And I've broken the talk up into segments where I'll show you some data from the approved medications, and these are all ones that have some activity at opioid receptors. And then the new medications that have been studied that don't have activity directly at opioid receptors. Just to tell you what I'm going to tell you, there's generally good translation from preclinical to clinical for opioid medications, for the most part. There's actually one notable exception that I'll describe. And then the translation from non-opioid medications to, from the preclinical to the clinical is, it's not so great actually, surprisingly. And so, the question really is why? And hopefully we'll have time at the end to kind of delve into this question. And just so that you can sort of see where I'm coming from, I'll just tell you a little bit about my background. I did all of my graduate training and my postdoc actually using preclinical models. So, and it was, I was using those models to kind of characterize the receptor pharmacology of opioids. And then, soon after my postdoc, or right after my postdoc, I came to Columbia and started doing research using those same models and trying to apply them to clinical populations. And I've done some clinical treatment types of research as well. So that's sort of where I'm coming from. So the target indications for opioid use disorder include maintenance therapy, and these are the most commonly used medications, so methadone, naltrexone, and buprenorphine. There are medications for specifically treating opioid withdrawal. Methadone was the first one that was approved for this indication a long time ago. Lofexidine is the most recent medication for treating opioid withdrawal. It was approved in 2018. It's an alpha-2 adrenergic agonist. For treating opioid overdose, we have naloxone and then also nalmefene. These are fairly non-selective opioid antagonists. More recently, there were formulations of naloxone or newer formulations that were improved, including an intranasal form. And then, there's one question that has sort of been discussed in the literature anyways. So Nora Volkoff had a paper a couple of years ago describing, craving and whether or not, we should be developing medications for that particular effect that opioid users very commonly report. So the preclinical models for maintenance medications include, or medications development for maintenance therapy are the conditioned place preference, intracranial self-stimulation, IV self-administration is the gold standard, and then also drug discrimination is a very useful tool in this regard. In the clinical setting, the effects that are most commonly evaluated are subjective responses using questionnaires, and I'll just kind of briefly describe a couple of those. The drug discrimination model is used in people, but less frequently. It used to be used fairly routinely at Johns Hopkins by Kenzie Preston, but there are fewer people doing this. The drug discrimination is used nowadays by Craig Rush and his group. And then self-administration is something that is used by different groups, including our group and then others as well. And there are various ways of looking at self-administration in people using operant procedures or just verbal choice procedures. And Roland Griffiths at Johns Hopkins developed this multiple choice procedure, which is it's not really measuring reinforcing effects in many situations because they don't actually administer the drug, but it's a kind of a proxy for reinforcing effects. So just to briefly go over some of the preclinical models, this is the conditioned place preference, and it measures the ability of the stimuli associated with the drug to influence behavior. So the drug is administered to the animal and paired with one side, and then on other sessions, the drug is paired with another side, and then the animal is allowed to choose which side they want to spend time in. So that's kind of the primary dependent variable for this procedure. The intracranial self-stimulation is one where they implant electrodes into the medial forebrain bundle to measure the ability of the drugs to modify responding for the stimulus that is believed to be associated with reward. So the animal presses the lever in order to get, stimulation in that brain region. The intravenous self-administration one is probably very familiar to you guys. An intravenous catheter is placed into the animal, and then it's connected to an infusion pump, and the animal learns to press the lever in order to get infusions of the drug. Placebo or saline is usually put into the infusion pump as well, and this is a direct measure of the ability of the drug itself to influence behavior. So this is kind of considered the gold standard. The drug discrimination paradigm is one that measures the ability of the test drug to elicit responding on a lever that was previously associated with the training drug. So basically the animals are made a little bit hungry usually. So they're working for food reinforcers, and they get an injection of either drug or saline. So, and it's paired with one side. So during training sessions, if they got a drug injection, they have to respond on the right lever, for example, to get a food reinforcer. And then when on a separate session, if they get a saline injection, they have to respond on the other lever to get the food reinforcer. And eventually they learn to discriminate whether they got drug or saline by selecting the correct lever. And then under test conditions, you can give a test drug and then see which lever the animal responds on to measure the similarity of the test and the training drug. So for the clinical procedures for maintenance medications, we have these types of models. So the subjective effects is very simple. It's, the primary endpoint that's most commonly used is a question that gets at liking. So this is a 100-millimeter line. The statement at the top of the screen would be, I like the drug. And then the subject responds somewhere along this line about how much they like the drug effect. So they either dislike it very much or like it very much, or they neither like nor dislike. And so this is what we measure. So this is what's called the bipolar scale, and this is one that's very standardly used by the FDA for assessing the abuse liability of a drug. We also ask a whole bunch of other kinds of questions that get at drug effects, including I feel high, I feel a good effect, I feel a bad effect, et cetera. So we can kind of get a sense of what kind of responses the person is experiencing. So this is a self-administration procedure that I use in my lab. So it's a drug versus money choice procedure, and I use a modified progressive ratio schedule. So during a sample session, the participant will get an injection of drug and then $20, for example. And then during a later session, they work to receive either the drug or the money. They have multiple choices, and they're working for tenths of the drug or tenths of the money. So each trial, they work a different, they have to make a different number of clicks on a computer mouse in order to earn that tenth of whatever they've chosen. So in this example, the person chose drug on 7 trials and then money on 3 of the trials. And what I'm looking for here is the breakpoint, or is the highest ratio value that's completed for either drug or money. So in this case, if he chose 7 trials for drug, the breakpoint would be 1600. And then if he chose 3 trials for money, the breakpoint would be 200. And unlike the preclinical procedure, where oftentimes after each trial, the reinforcer is delivered, in this model that I've developed, they get the reinforcer all at once at the very end. So this person would have received 35 milligrams of drug and $6. So he'll get the money that goes into a bank, and then the dose, and then hopefully is happy. There are other, so for looking at withdrawal, so this is one of the other indications that we talked about. There are various models that are used in the preclinical setting. So one is a substitution procedure where an animal is made physically dependent on an opioid, for example, and then the test drug is substituted out for the maintenance drug to see whether or not it can continue to suppress withdrawal. Another procedure that's used is naloxone precipitated or abstinence-induced withdrawal. And then Charles France has a drug discrimination paradigm that he uses often to look at withdrawal effects as well. In the clinical situation, we use substitution procedures, naloxone precipitated withdrawal, and then also drug discrimination has been used in this context. One indication that overdose. So if somebody has taken too much opioids and you want to try to reverse the overdose, then there aren't very many good models for this, actually. In the preclinical setting, you can look at reversal of severe respiratory depression that's produced by an opioid agonist. In the clinical setting, that's possible as well, but it gets a little tricky because, you obviously don't want to harm your research subjects. So doing this type of study is a lot more, you have to be a lot more careful. And so the newer formulations of naloxone, for example, didn't rely on a reversal type of study because naloxone has, a very well characterized pharmacology. The FDA just relied on pharmacokinetic data, showing that the onset and peak effects and duration of action were similar to, the approved product. So craving is something that we've talked about in the field for a long time, and a lot of data that Kenzie Preston, for example, has collected are, finally showing a really nice correlation between craving and actual drug use. So she has a really nice model that she's using called the ecological momentary assessment, where people carry a cell phone-like device and then they answer questions about how they're feeling and indicate when they actually use drug. In the preclinical model, craving is usually kind of characterized by responding for conditioned cues associated with the drug. So either the light or the sound that's associated with the drug administration. And so the animal doesn't actually get the reinforcer, he just gets the secondary reinforcer of the, which would be the conditioned cues. So in terms of craving that's most commonly used, we look at subjective reports. So the visual analog scales, it's simple question of I want heroin or I want tobacco, or, validated questionnaires as well. There are models that use stress, drug cue, or negative affect induced craving. So Rajita Sinha does a lot of this work, and it's, you know, really beautiful research that she does. And then also we look at cue reactivity. I want to first walk you through, you know, some of the medications that are already approved for treating opioid use disorder. And I'm going to go backwards, starting with the effects of these medications in the treatment setting, and then also show how they operate in the human lab setting, and then describe the data that have been collected in preclinical models. So the three that I'll describe, as I mentioned earlier, are naltrexone, which is a non-selective opioid antagonist. I mean, it has some selectivity for mu, but you know, maybe only tenfold for mu versus kappa, for example. Methadone is a full mu agonist, and then buprenorphine is a partial mu agonist and a kappa antagonist. So in terms of treatment, these are data that Evgeny Krupitsky collected, you know, about 10 years ago to evaluate Vivitrol. It's an extended release form of naltrexone. And he randomized people to, so they, this is the, you know, retention and treatment. So of course it's close to 100% at the beginning. And then half of the subjects received the active medication. So this is naltrexone, and then half received placebo. And you can see that by about 6 months, so this is, you know, this line just denotes 50% retention. There's a superiority of extended release naltrexone over placebo. Buprenorphine and methadone. This is a study that was conducted in Scandinavia where they titrated the medication to effect for each individual patient and compared the effects of methadone and buprenorphine. And again, this line is showing the 50% retention in treatment rate. Methadone and buprenorphine produce about 50% retention after about 6 months. So, you know, all three medications are doing what we're hoping that they would do. They, you know, help retain people in treatment. And you can look at these numbers either as a glass half full or glass half empty sort of thing, where, you know, some people are, you know, only about half the patients are retained, which is not great, but half the other, you know, the other half of the patients are retained. So that's a good thing too. So what do these medications look like in the human lab? So this is a study that we ran in my lab where we were looking at another sustained release formulation of naltrexone. It's not Vivitrol, it's another product that never actually made it to market, but it was very similar in terms of its, you know, PK. So what I'm showing you here are the breakpoint values. So these are the self-administration data for heroin. And then these are ratings of I feel a good drug effect. Each panel represents a different week during the study. So this was done on an inpatient basis. So everybody, we screened everybody and brought them into the hospital. So they lived in our facility for about 7 or 8 weeks. We had a baseline session where we measured heroin self-administration and subjective responses, and you can see these nice dose-related increases in both endpoints. And then at the beginning of week 1, we administered the sustained release naltrexone and found a complete antagonism of both effects for up to about 4 weeks. And then, you know, we started seeing a slight recovery in effect here at 4 weeks. And then by 5 weeks and 6 weeks, they had pretty much recovered to pre-naltrexone levels. So looks good. It's consistent with the clinical data. We also examined the effects of buprenorphine. This was sublingual buprenorphine, where people were maintained on the medication. We looked at self-administration again, and this is for ratings of I feel high. And this is the heroin dose response curve. So these numbers in gray here are from another study, actually, showing that, you know, heroin self-administration is quite high when active doses are administered compared to placebo. When we started to increase the maintenance dose of buprenorphine, we got these dose-related decreases in both self-administration and subjective responses. Methadone also shows the similar pattern. So these are data that were collected by Eric Donnie and Sharon Walsh's lab. Top panel is self-administration, bottom panel is subjective responses. This one is for strength of drug effect. And as you can see, under the 3 different methadone maintenance dose conditions, they got this dose-related suppression in both effects. And these doses of methadone are commonly used in clinical settings. So what about the animal lab? This is data from James Rowlett's lab for naltrexone. These are individual monkeys. This is a baseline heroin dose effect curve for IV self-administration. You can see all 4 monkeys self-administered heroin, at least at you know, in a dose-related fashion. And then when naltrexone was on board, there was a large rightward shift in the dose response curve. So that was nice to see. These are data from Steve Negus's lab. He has a heroin choice procedure where they're choosing between heroin and food. And he showed that heroin by itself, you know, maintains choice behavior. And then when there are increasing doses of buprenorphine, you get these rightward shifts in the heroin choice curve. These are data also from Steve's lab. So this is where it gets a little funky in the monkeys. So I'm not sure why this happens. And I had multiple conversations with Steve about this, and we don't really know why this is happening. I went back and I like scoured the literature, and there's some, you know, older papers by Nancy Mello and David Downs showing exactly the same thing. So for some reason, under methadone maintenance conditions, you can't get shifts in the heroin in heroin self-administration. It's really weird. Like David Downs actually really pushed the dose very high and showed that, I mean, at doses that were lethal to the monkeys, he couldn't get a shift in the dose response curve. So it's really unclear why this happens in monkeys. It looks fine in rats. So I don't know why this happens here, but this is one example of something that doesn't translate well. So now for the non-opioid medications, I want to go the other direction. So I'll show you some data from the animal lab and then, you know, human lab, and then also treatment setting. And I'll use 3 examples: memantine, lurcaserin, and abutolast. So memantine is a low affinity NMDA antagonist. Lurcaserin is a 5-HT2C agonist. And Ed was telling me just before we started that, you know, you guys have done some work with both of these medications, actually. Abutolast is a non-selective phosphodiesterase inhibitor. I was interested in it for its activity as an inhibitor of glia. You know, some exciting new or exciting data that have been generated over the last several years on the role of glia in, you know, abused substances. So we tested the effects of abutolast and several other compounds that have, you know, activity at glial sites. Start with memantine. So it is a low affinity NMDA receptor antagonist. So it kind of is not quite, it acts at NMDA receptors, but it's not quite as strong, I guess I would say, as phencyclidine, for example. It so this one's a little bit clearer. It acts within the channel as well. It doesn't have quite as much of the cytotomimetic effects as PCP does. So, you know, it was thought that the side effect profile might be better with memantine than with something like PCP or ketamine. I'll just quickly walk you through some of the preclinical studies with memantine. This was an old paper that was published in 1998, looking at the discriminative stimulus effects of memantine. This is animals who are trained to discriminate PCP from saline. So you see a nice dose-related increase in PCP lever responding, the PCP-associated lever. When memantine was substituted for PCP, it did not, or when memantine replaced PCP, it did not substitute for the training drug, up to doses that produced, sorry, I'm getting this wrong. This is PCP. This is saline. So PCP is PCP lever is selected 100% of the time when PCP is given. Saline is the saline lever is selected 0% of the time. Memantine does substitute for the PCP discriminative stimulus, but only at doses that produce very large suppressions in the response rates. So that makes it a little bit more difficult to interpret these data. And then these data are with amantadine. So I apologize, I haven't looked at this figure in a little while. So memantine does seem to share some discriminative stimulus effects with PCP, which kind of makes sense. It's, you know, has a similar mechanism of action. So this is self-administration of PCP, memantine, and amantadine. So this is amantadine down here, memantine here, and PCP in 4 different monkeys. So PCP maintains pretty robust self-administration. This is the mean number of infusions that the animals self-administered. Memantine is also self-administered by all of the animals, but they took far fewer infusions than they did of PCP. And then amantadine was not self-administered at all. These are data that were collected in rats using a conditioned place preference model. So they this is a food preference, a sexual interaction preference, and this is morphine conditioned place preference. Okay, so memantine is here, and then the unconditioned stimulus is shown down here. So morphine is available in the absence of memantine. There's a clear place preference for the morphine paired side. When memantine is added to the mix, it blocks the conditioned place preference that you can see with morphine. That was encouraging. Memantine looked like it was kind of had a mixed bag here. It shares discriminative stimulus effects with PCP in both rats and monkeys, served as a weak reinforcer in the monkeys, and it reduced morphine-induced conditioned place preference in rats. So there were, a bunch of other studies with, with NMDA antagonists at this time to suggest that maybe this mechanism would be interesting. So we decided to study it in people. So I collaborated with Adam Basaga on this study, and the first thing we looked at was, memantine's ability to reduce opioid withdrawal symptoms. So we brought, heroin users who are physically dependent into the hospital. We maintained them on morphine. And then we gave naloxone during separate sessions. Here we varied the time, of naloxone administration relative to the memantine administration to try to capture the time course of memantine's effects. We gave memantine 42 hours before the naloxone, We got pretty, substantial withdrawal symptoms. The CINA is a withdrawal scale. That lasted for the expected duration of naloxone's effects. When naloxone was given 6 hours after the naloxone dose, we got this suppression of withdrawal symptoms. And then as the time, was increased, we saw this kind of recovery of withdrawal symptoms. So Adam and I collaborated on this study in my lab where he was really kind of interested in seeing whether memantine might be useful for reducing the reinforcing effects of heroin in our population. In this study, we actually detoxed people because we were thinking that maybe we can see a more robust effect in people who are not physically dependent on opioids. So again, this is, heroin self-administration in the placebo memantine condition. So when the control placebo, this was lactose powder, was given, they didn't choose that option very much at all. But then when active heroin was available, they self-administered quite a bit, or the break point was much higher. And then we tested under maintenance on 30 and 60 milligrams per day of memantine, and didn't really see any, change in heroin self-administration. 50 milligrams of heroin was available. When a lower dose of heroin was available, then it looked like the lower dose was effective. So it's not a dose-related effect here, but it was statistically significant. So we thought, okay, it's not dose-related, which always kind of makes me wonder. So we looked at the subjective responses as well. So what I'm showing you here on each panel is the effects of placebo heroin. The middle panel is 12.5 milligrams of heroin, and then 50 milligrams for the amount that people would be willing to pay for the heroin. So of course, when they just had lactose, they wouldn't pay anything for it. When they had the 50 milligram, they would pay, roughly $10 to $15 for the heroin. And when memantine was on board, we got this, dose-related reduction in ratings of how much they would be willing to pay for the memantine, for the heroin. So that was kind of, a step in the right direction. We also looked at ratings of I want heroin, and you can see that, they always want heroin. These are heroin users, so craving tends to be pretty high. And memantine seemed to produce some, decrease in ratings of wanting heroin. This sort of pattern of effects happened for a whole bunch of the other subjective responses. So I feel a good drug effect, the dose was potent, the dose was of high quality, I like the choice, and I feel high. So, the subjective effects data were pretty encouraging. The self-administration was more modest. And so we were kind of thinking, well, let's just see what happens in the treatment setting. So Adam ran a study where he was using it to as an adjunct to oral naltrexone. So it's placebo, 30 and 60 milligrams of memantine as a maintenance in combination with oral naltrexone. And there were no significant effects of memantine on either treatment, retention in treatment, heroin use, withdrawal symptoms, or craving. So that was disappointing, but Adam is very persistent. And he did another study where he gave it as an adjunct to sustained release naltrexone. And this is showing withdrawal symptoms. And so this is a subjective opioid withdrawal scale here. This is not quite significant. I'm not supposed to say that, I know, but but okay, it was not significant here. And this was the thing that was sort of the nail in the coffin for memantine. They actually had more completers in the placebo group compared to the memantine group. So the research subjects didn't like, or the patients didn't like the way that memantine was making them feel. And so they dropped out of the trial. So lorcaserin is the 5-HT2C agonist that I think you guys have studied as well. So this is, I'm just going to quickly go through here because I think I want to have some time for discussion at the end. These are the data that Catherine Cunningham collected. Harshni Neelakantan was the lead author on this trial. So lorcaserin produced this nice dose-related reduction in oxycodone self-administration that was reversed by the 5-HT2C antagonist, SB242084. Yeah, this is total lever presses, under extinction, and then saline conditions. Lorcaserin dose-dependently increased smoking cessation and prevented the associated weight gain that typically occurs with smoking cessation. So these, I mean, there were other signals with lorcaserin that made it really kind of interesting as a medication to test in humans. And at the time that we ran our study, looked at it in people who have opioid use disorder. We ran this study where that was, again, 7-week inpatient. We detoxed people in the beginning, stabilized them on lorcaserin, either 0 or 10 milligrams BID, and then did a series of tests with oxycodone. We looked at self-administration and then also extinction and relapse with placebo oxycodone. So here this week they had active oxycodone and this week they had placebo. This was all a completely within subjects design. During the test weeks, we gave them a sample of oxycodone and $10. Then they had opportunities to choose between the two options for multiple days. And then on the last day, so this was a Friday, sample oxycodone and then have a Q reactivity session, and then a progressive ratio choice. And we did the same thing under placebo, on the placebo week. So here we were looking for kind of extinction-like responding, and then also to see whether, we could see any increases in self-administration. So we enrolled 18 people and 12 completed. And these were the dropouts. So 2 dropped out because they just didn't want to be on the inpatient unit. 1 was complaining of withdrawal symptoms, so he dropped. 2 were discontinued for non-compliance with unit policies, and one was discontinued by us actually because of possible delusions and mild paranoia. So these are the demographics, mostly men, pretty, wide distribution of ethnicities. These guys tend to be in their mid-40s, and they typically use between 5 and 6 bags a day of heroin. So one street bag costs about $10. They're daily heroin users. Some of them also use prescription opioids. Most of them, use stimulants, or not most, but, a proportion also use stimulants like cocaine, sedatives like benzos. Some use marijuana. Most of them smoke, and then some drink alcohol. I'm showing you the pupil diameter data here first. So just to compare, oxycodone decreases pupil diameter compared to placebo. So this is placebo. This is like lactose powder that we gave. When they had active oxycodone on board, the pupil diameter was lower, which is what you would expect. When lorcaserin was also on board, it produced this significant decrease in pupil diameter. Not sure what to make of that, but just want to show you what happened. With systolic and diastolic pressure, when lorcaserin was on board, we also got these pretty robust decreases. I talked to, cardiologists about this, and it's not clinically significant, these changes, but they were statistically significant. So that's one thing that I want to talk to you guys about later. So this is the self-administration data. During the active oxycodone week, they self-administered, they chose the drug option the majority of time. When we switched them over to lactose powder, so this is the placebo, they didn't choose the drug option at all, very much at all. And lorcaserin had no effect on drug choice. These are the breakpoint values on that Friday session, as I mentioned, and there was basically no effect here either. These are ratings of drug liking on the oxycodone weeks compared to the placebo weeks. This is statistically significant. So, when they had lorcaserin on board, so this is a little bit weird the way it's graphed here, but they reported feeling very little effect of oxycodone under placebo conditions here. This is a pretty low dose of oxycodone. But then when lorcaserin was on board, we got this statistically significant increase in ratings of drug liking. Again, the effect size is something that we need to talk about because, this is not a very large effect, but it's going in the wrong direction because it's increasing liking for oxycodone. When placebo was available, we didn't see anything. These are ratings of good effects, same pattern. Strength of drug effects, bad effects, so there's nothing. And this is ratings of I want heroin. And lorcaserin seems to produce a larger increase here. So all of these subjective responses are going in the wrong direction. The medication was well tolerated though, which was the good news. So, lorcaserin doesn't seem to have much, much use here, at least under these experimental conditions. So it didn't alter self-administration, and it produced small but statistically significant increases in a bunch of subjective ratings. And it increased craving, but it was well tolerated. So that was the one bit of good news that we had. So we concluded that this dose of lorcaserin anyways might not be effective in treating opioid use disorder. So the last medication I want to talk to you about is abutolast. It's a non-selective, the non-selective phosphodiesterase inhibitor. So this is a study that was conducted in rats by Mark Hutchinson. He showed that it decreases withdrawal symptoms. It potentiates the analgesic effects of morphine. Sorry, this is animals who are made physically dependent on morphine. They went through withdrawal, and AV411 is is what it was called, during testing. So this is abutolast. Here, morphine produced an analgesic response on its own. And when abutolast was on board, they got a leftward shift in the dose response curve. So this is kind of weird because, I was like, okay, so, well, actually not entirely weird. I was like, okay, so if it suppresses withdrawal, that's kind of consistent with a mu agonist type effect, and it's potentiating analgesia. So my first question was, what's going to happen with self-administration then? Because you would expect that you get kind of a potentiation of everything. Here I'm showing you that it increases the duration of the analgesic response. But shoot, I didn't show you, but in terms of, condition place preference, it actually reduced condition place preference, and it reduced morphine induced increases in dopamine release in the nucleus accumbens. So the effects of this compound were really complex and very sort of counterintuitive. So we decided to test it in the lab. We detoxed people from opioids, stabilized them on either 0 or 50 milligrams of abutolast, and then ran choice sessions. So they received a sample of oxycodone and then had the progressive ratio breakpoint, a progressive ratio procedure here. So we tested 3 different doses, 0, 15, and 30 milligrams of oxycodone. We crossed everybody over to the other dose midway through the study, and then we did exactly the same doses for testing here. What we found was that, under placebo conditions, oxycodone was self-administered more than the placebo oxycodone. And when abutolast was on board, we got this pretty substantial reduction in self-administration. So that was really nice to see. But here it was funny because, like, for the subjective responses, we didn't see a whole lot of change. Usually for subjective effects and self-administration, they travel very nicely together, but that didn't happen here. But it did seem to reduce craving. So these were ratings of I want heroin. Abutolast, significantly reduced that. They reduced craving for cocaine, and also ratings of I want tobacco. We looked at analgesic responses as well, but I won't talk to you about that because I want to just get through and sort of discuss. So abutolast was safe and well tolerated, reduced the reinforcing effects of oxycodone, but not this, and craving, but not the other subjective effects. So we thought maybe this medication might be useful for enhancing relapse prevention. Again, there's good translation from the preclinical to the clinical to treatment data or studies for opioid medications. And as you can see, there's like kind of so-so translation for the non-opioid medications. So to me, the question really is why? Why does this happen like this? One very knee-jerk reaction is, oh, they're just species differences. Another, which is true, because sometimes the metabolism of the medication is different in the different species. We've seen that for some of the other medications. And so this is kind of a very important thing that we have to think about it. Another thing is the dosing limitations. So I think this has been a really big issue for medications development for cocaine use disorder, for example, because you can really push the dose in the animals, but once you put them into people, they don't tolerate those doses, and so they don't take it. So medication side effects or medication compliance is a big issue. So that's one thing that really needs to be paid attention to a little bit more, I think, in the preclinical arena, is trying to get a handle on what might be dose limiting. The models, are another thing that we might need to tweak to improve the translatability. The effect sizes, I think, are something that we just haven't paid nearly enough attention to. So say you get a statistically significant decrease in an effect that you're looking at. That's great, because you always want to have a positive finding. But what is the effect size in both the animal models and the human lab condition as well, that will translate into a clinically meaningful change in treatment outcomes? Because that's the end goal, right? Is to improve that. So we kind of came up with this decision algorithm here for a medication, looking at a positive signal, promising signal, or a negative signal. So if you get a negative signal, obviously you just stop. A positive signal means a decrease in positive subjective effects and maybe withdrawal and self-administration, so it goes to a clinical trial. And then a promising signal is where you have to start making some hard decisions. What if it decreases positive subjective effects? Maybe you combine it with buprenorphine naloxone. what if it decreases withdrawal symptoms? Maybe it's useful for, you know, either combining with naltrexone or getting people, you know, onto naltrexone. And then if you get a positive signal, then you go to a clinical trial. So lorcaserin is an example of a negative signal in our minds. Memantine was the promising signal, and then it ended up stopping here. Buprenorphine, methadone, and naltrexone were positive signals in all of these endpoints. And then abutolast, you know, what do we do here? I don't know. That was the question mark one. So I want to thank my lab. This is kind of an old picture, actually, but call out Jermaine Jones. He's a not so junior faculty member anymore. Jeannie Manubay is our medical director. Shanti is also a physician in the lab. And then we have a whole slew of other people who are, you know, really core parts of our team. And, oh, I can't show you this. I was going to leave you with a happy note. I love this little video of a baby dancing. So anyways, okay, so I'm happy to take questions.
Well, thank you, Sandra. That was a wonderful survey of these different examples in terms of the animal and human studies. So we have a little bit of time here. I just want to ask one quick question. I mean, another difference between the animal studies and human studies that I assume these heroin addicts that you're dealing with have been taking heroin for years and decades at a time, and so they have a much longer history than any animal study I know of, and often even people who have extended pre-training of the animals, it's maybe weeks. So I just wondered, in terms of the comparability of the drug experience, whether that is one impediment to the translation.
I mean, that's true, and sorry, I was trying to. So I guess I would say that maybe that's partially true. But for the monkey studies, for example, some of those animals have been self-administering opioids for many years.
Okay.
So that might be more comparable to what's going on with people. And the rats too, actually, if you think of, you know, just sort of stretching out their lifespan. Yeah. But yeah, that's another thing that might be, you know, an important factor in why, you know, it's so different sometimes, the results across the different.
Good. So are there other people who have questions or comments? I mean, I can, Amir, can you unmute yourself?
But thank you for a great talk and lots of information. Thank you. I have a quick question. When you give money for as a reward, I think that the level of reward for that money for different people is different. Like, you know, if you give $20 to a anesthesiologist heroin addict versus a homeless heroin addict, that means two things, right?
No, you're raising a good point. And we did a lot of parametric studies in the beginning to make sure that, you know, the data are reproducible. So the quick answer is that it is. I mean, you know, I was really curious actually about what both the self-administration, you know, and the subjective responses might look like across time, because we use sort of the same model and similar doses. And I graphed those data and they're right on top of each other. So even though I take your point that there's some amount of variability, you know, individual variability, it doesn't seem to be enough to affect the outcomes that we're looking at.
Okay, great. Another quick question. Did you see a gender difference with these drugs, males versus females?
Yeah, we haven't done any, in the heroin users, we haven't done any sex difference studies because I would say, like, you know, 75, 80% of our population is male. So I don't know about that. I mean, that's another really critical variable that I think is always very important to look at. And in other studies that I've run, so I am very interested in sex differences, and so in normal healthy volunteers and then also recreational opioid users, I looked at some of those questions. And for morphine anyways, there do seem to be some sex differences in responses, certain responses. Whether or not we see medication differences as a function of sex is not something we've looked at, very often. Are you thinking of something in particular?
No, I was just wondering that if the effect of the drugs is different in different sexes.
This is a 40-year-old question. Back in the late 70s, early 80s, Charlie Llewellyn and I opened the first methadone program here in Durham. And it was back when you had to detox patients within a relatively short period of time, over about 6 to 9 months. And they could select either a self-administered detox or a blind detox. And we would encourage the latter. What we never understood was we could literally get people off the methadone over a period of about 6 months. And then we would not tell them that they were no longer getting any methadone. They were just getting the substrate that was administered. 2 weeks later, we would tell them that they had been off methadone and they would go into measurable withdrawal. I mean, significant. The pupil dilation, goose flesh. Can you explain that?
Not easily. I've seen that. I mean, I know exactly what you're talking about, and it's an expectancy effect. I mean, I can't call it a conditioned response because there's nothing that's conditioned there.
Right.
But in our withdrawal studies, I always use a blinded, abrupt switch to placebo, because if I tell them or just stop giving them the morphine and then say, they'll go through like really severe withdrawal. So, that's my high level label for that phenomenon. But I don't, other than expectancy, I'm not sure why that happens.
Okay, thank you.
Yeah.
Any other questions?
So thank you for your very interesting talk. My daughter, by the way, is working at Barnard and just graduated from there.
Oh, great.
So my question was about fentanyl. So I know that you're using heroin as your substrate for a lot of your studies. Around here, probably in New York City as well, much of the heroin is being substituted for fentanyl or mixed with fentanyl. And I think the fentanyl effects may now be essentially the primary thing that people are getting when they buy illicit drugs and use them. And I'm wondering, should the studies now be done with some mixture or with fentanyl alone to get a better kind of real world idea of what might be effective?
Totally. I think, yes, I think it should. Fentanyl is a lot trickier to use. We have studied fentanyl for, in our self-administration model. So fentanyl by itself, at least in the New York City area and probably nationwide, is most often cut into the heroin. That kind of introduces another level of variability. But yeah, I mean, I think we should be looking at fentanyl because like in my training, I was really interested in the whole receptor pharmacology and efficacy differences across the mu agonists. So when we were looking at morphine versus fentanyl versus nalbuphine, for example, the pattern of responses is very different. And fentanyl itself is, has a lot of sort of nuances in its pharmacology that are not shared with other mu agonists. I mean, they're all mu agonists, of course, but fentanyl, for example, has different, activity at the beta-arrestin site than the other mu agonists. Morphine looks like an intermediate efficacy agonist, so it has some, differences in that way. Fentanyl also produces the muscle rigidity that's less common with the other mu agonists. And I kind of like to talk to people about differences in preference for different mu agonists. It used to be thought that, well, one mu agonist is just like another, it's all acting at the same receptor. But there are these nuances that people like or dislike. For example, they really dislike morphine because morphine has a very strong histamine response, or produces a very strong histamine response, and they don't like that effect. Whereas oxycodone or hydromorphone don't, and they love it. We're doing a study right now comparing intravenously administered oxymorphone, hydromorphone, oxycodone. We were also looking at morphine, but ended up dropping morphine because they hated it so much. So yes, I did. I'm sorry, that's a long answer to your question, but I really do think we should be looking at fentanyl, not only for its direct effects in terms of, subjective responses or reinforcing effects, but also because what we're seeing is that people who are physically dependent on fentanyl have a very different type of withdrawal response. So the withdrawal is very severe. They become incredibly impulsive. I mean, I've been doing this research for, like 25 years. And we had a really good handle on a heroin user, bringing them into the hospital, maintaining them on morphine. And our dropout rate, we used a combination of clonidine and benzos to treat some of these withdrawal symptoms that they experience in the beginning. And our dropout rate was fairly low. Now with fentanyl, it's a whole different ballgame. I mean, they go through severe withdrawal. They boom, they're out the door. They're just they're really impulsive. For the first time, just like last fall, actually, this is funny and not funny. We had somebody we brought into this oxymorphone study that we're running, so they were maintained on morphine. They went through some pretty severe withdrawal in the first couple of days. We brought them, we took them outside for a cigarette smoke, actually, right before we started our lab sessions. And this person literally started running down the street, took off. The staff member was freaking out because, they just left with, flip-flops on their feet because they wanted to go out and use again. I mean, it was unreal. And that's what they're doing. They're just really impulsive. They're going through severe withdrawal. It's a different beast than heroin is.
I had one more question. Then we'll finish up, I guess. In a lot of our studies, we see differences between high and low responders in terms of drug effects and in a variety of different treatments. But like people, rats, so some of them like either nicotine or remifentanil or cocaine, and others less so. And so if we would do just high versus low responders and then give them treatments like memantine or lacastrin or other drugs, 18-MC, then we do see differences in response with the high users versus low users. And I just wondered, in terms of some of the clinical lack of significant effects, it might be hidden in there in terms of these individual subgroup differences that I don't know if people tried to parcel out high versus low users or frequent versus infrequent users, things like that.
I love that suggestion. I didn't even think about that. So Jim Zachney has kind of taken a look at that with some of his data. Mm-hmm. And shown some differences in not so much for medications, but for acute effects of the drugs. But that's a great suggestion. I'm actually going to go back and look at some of our data and see, because we do get people who are, who have much higher breakpoints, much higher ratings of drug liking and all that kind of stuff. Yeah. It all washes out when you graph up means, but But yeah, so I don't know. I haven't actually looked at my data in that way.
Oh, okay.
Yeah, no, that's a great suggestion.
Well, thank you. And thank you for a great talk and very enlightening. And I hope everything goes well with your future studies. And thank you again. And November 18th, Dr. Roy Stein and Dr. Robin Jordan will be talking to us about expanding access to opioid use disorder, the hub and spoke model. And that'll be noon on Okay, thank you, Sandra.
Thank you,
and,
guys.
Thank you.
Thank you very
You're
much.
welcome.
good rest of the day.